Hello, everyone. How's everybody doing? If you've got the bandwidth, let me see you on the screen so I can see the people. All right, so we've got class today. The weather didn't create the power outages I thought it might. So welcome, everyone. All right, what is the most feared disease? Somebody shout it out for me.
Cancer.
Got it. And there are reasons for that. We're going to talk about some of the psychological reasons why it makes sense that this is the most feared disease. So remember, coronary heart disease is #1 cause of death pre-pandemic, cancer #2 cause of death. It accounts for about 23% of all mortality, and 1/3 of women have a lifetime risk. So 1/3 of us will have cancer at some point during our lives. All of us, I don't mean to scare anybody, but all of us have probably had cancerous cells in our body, but our immune system, if it's been effective, has found those bad cells and removed them from the body. Men are more at risk for cancer than women. There's some genetic aspects to that. There's some risk factor aspects to that. But African Americans, particularly African American women, are more at risk than white women in our culture. Okay, so let's get a textbook definition of what is cancer. Cancer is kind of inevitable for mammals, and it's really 100+ family of diseases, but it's characterized by uncontrolled growth of abnormal cells. So cells that have been mutated and they're abnormal. But I want you to know you can get uncontrolled growth, like think about like a mole, which is sometimes even called a beauty mark. That's uncontrolled growth of pigmented cells, but it may not be cancer. It could just be uncontrolled growth of normal cells. So cancer is the uncontrolled growth of the abnormal cells. Because all of our organs in our body are made up of cells, technically cancer can affect any organ anywhere in the body. And it's because of either inherited, like the BRCA genes that create breast and ovarian cancer for women. That would be an example of some inherited genes, or it could be an acquired genetic mutation if we're exposed to radiation, if we're exposed to toxins, if we're exposed to carcinogens. And these injured cells heal themselves by replicating by creating new cells. And within the cells, there are 2 genes that control cell growth. And I like to think about the oncogenes, and you see this in the roots of the word oncology as an example. The oncogenes are like an accelerator in a car. So they tell that cell, let's replicate, and let's replicate quickly. Okay. And you can injure, if you've got an injury to the oncogene, you could have uncontrolled growth of abnormal cells. The flip side of the oncogene, that's like the car accelerator, the suppressor genes within the cell are like the brakes. And so the suppressor genes say, whoa, slow the replication, slow it down. And so normally you've got this homeostasis between the accelerator and the brakes, that ideally you're creating the right amount of replication for healthy cells, but you can injure either one of these and get cancerous growth. Okay, so the genes that create normally homeostasis, when they get injured, you lose that homeostasis and you get that uncontrolled replication. So any questions about what cancer is? When I was little, the president at the time in the United States created this war on cancer. And interestingly, within our language, we still kept a little bit of that war language, like you fight cancer, that kind of stuff. And when I was little, it sounded like a great idea. Yes, let's get rid of cancer. The more I've understood cancer and learned about it, I've kind of understood that it's kind of inevitable for a lot of individuals. Like it's a part of normal life, unfortunately, for a lot of individuals. These are the major 4 types of cancer, but the most common, and this is going to ring to your intuition here, the most common are the carcinomas, where the cancer attacks epithelial cells. And this is the majority of adult cancers. And it's in the organs that you all are familiar hearing about people having cancer. So breast cancer, prostate cancer, colon cancer, lung cancer, pancreatic, skin cancer. So the majority of the stuff that you hear about are the most common forms of adult cancer. The other three most common, and keep in mind there are other cancers beyond these top four, but I'm just kind of giving you the ones that you probably have been more familiar with, heard about. The sarcomas are cancer to muscle, bone, cartilage. The lymphomas are when we get in our lymph system, which kind of drains our blood throughout the body. A lymphoma would be cancer in the lymph. And then the leukemias would be cancers in the blood or the bone marrow that create abnormality of white blood cells, red blood cells that are made in the bone marrow and then float through the blood. So those are the four major types. And I want to get some just terminology down here so that we're all on the same page when we use this language. Malignant means that whatever cells we're looking at are cancerous. Benign means whatever cells, and usually this is a pathologist looking at these cells. Benign means that the cells are normal and not cancerous. Okay. A tumor, oopsie. A tumor is a solid mass of cancerous cells, or it could be a solid mass of normal cells. And again, beauty mark would be an example of normal cells. And then metastasize wherever a cancer begins, and we usually name the cancer based on the organ where it starts. So lung cancer starting in the lungs, breast cancer starting in the breast. Metastasize means that it's traveled. And as it's traveled and set up camp in other organs, we call those METs or metastasized METs. And depending on where the cancer begins in an organ and what type of cancer it is starting in that organ, the oncologist and hematologist will stage cancers in different ways. But oftentimes the staging is a characteristic of how big was an original tumor. So having like a teeny tiny breast cancer, very different than having a very large tumor in one's breast. And then it is staged based on, has it traveled from that original site into the lymph system? And so we ladies have lymph around our breasts as an example. So if you get diagnosed with the breast cancer, they're going to look and see, has it traveled to the lymph nodes surrounding the breast where the breast drains? And then they're going to oftentimes in the staging look at, can you find these cancers? Have they set up METs elsewhere? Okay. And some cancers are staged in 3 stages. Some are staged in 4 stages. It just depends on the type of cancer. But what this information gives us is what is the prognosis? What is likely going to be matched in terms of treatment options if an individual wishes to be treated? And then also kind of how lethal it could be. I mean, that's part of the prognosis of it. You know, are we going to probably successfully treat this, or is this likely going to worsen and create death? So that's what metastasizing and the staging does for us. Okay. I want to focus, I'm not going to focus here on men, I just want to focus on the women, but the most common form, and this, keep in mind, this is cancer deaths. So this is in what organ, what type of cancer that drives death. And the most common in women is lung and bronchial cancer. And certainly that is a function of firsthand cigarette smoking or secondhand smoking, being exposed to other individuals. Occasionally it's a function of being exposed to something like radon in the home or asbestos if you were exposed in the workforce to asbestos or that type of thing. But breast cancer is second. Okay, now women fear breast cancer, but it's number 2. And then after that, it's colon and rectal cancer, and then pancreatic, and then ovarian cancer. I do want you to note here that uterine cancer is, You've got ovarian cancer up here at 5%, and you've got uterine cancer down here at 3%. We're going to talk about PAPs and pelvics and that type of thing and the things that we do to screen. And many of you have probably been vaccinated for, like with Gardasil, to try to prevent cervical and uterine cancer. It's pretty low on our concern list, mainly if individuals have access to healthcare and they can get regular Pap tests. We've come a long way in being able to manage cervical and uterine cancer that way. Okay. So our risk, remember we said for women across our lifetime, it's at 1 in 3 for all sites. It's 1 in 8 for breast cancer. Sometimes you'll hear 1 in 10. Some of that variance happens to be, or are we looking at postmenopausal, or are we looking at all throughout the lifespan for women? 1 in 16 risk for lung and bronchial cancer. And this is a lot lower here, even though it's the #1 cause of cancer death, it's lower here because many women do not smoke, or they're not exposed to smoke. But when you do smoke, particularly if you smoke and also take oral contraceptives, that's especially dangerous for cardiovascular risks. And then the smoking is a risk for lung cancer. Okay, and then keep going down here. You see only 1 in 40 for the uterine and cervical 1 in 145. A lot of that has to do with access to healthcare. If we have access to healthcare and we get our regular pelvics and PAPs. If you look at cancer rates per capita, so in this case per 100,000 people in the United States, and you take a look, this starts back in 1930s and it ends in 2005. Despite what the media likes to do every now and then, they like to scare us. They know that we're easily scared by this kind of stuff, and sometimes they can make a story out of a cancer scare. But overall, in the last 100 years, cancer rates in different body parts have remained rather stable. And that's kind of where I go back to that part about how for us mammals, cancer is somewhat inevitable. It's kind of like a part of life. The things that have changed that environmentally have made a difference, we had a dramatic decline in stomach cancer in the last 100 years. And a lot of that has just had to do with refrigeration, being able to safely store food, not having to salt foods or smoke foods, particularly meats, in order to preserve them. A lot of the kind of the practices to try to keep food safe has improved. And so we're seeing significantly less stomach cancer. You see this dramatic increase in lung and bronchial cancer over time. And this little bleep for guys and prostate cancer right here, I'm pretty sure prostate cancer wasn't increasing starting in the 1990s, but doctors started screening for it. And if you start screening for something that's already there, you're going to find it. But keep in mind, many men are asymptomatic. They can have prostate cancer and be asymptomatic. And then a lot of men will have consequences from it. But I just want to talk about that little blip here. Okay. So overall rates have been pretty stable. The reason why we have seen these dramatic increases in the bronchial and lung cancer in both men and women is because of advertising in the 1950s and the 1960s. And if any of you are Mad Men, the series Mad Men, I loved Mad Men. It was all about these corporations that did advertising and started selling products through advertising. And the cigarette market was a big buyer of advertising back in the 50s and the 60s. And I just want to show you all this because if you haven't seen these before, you're going to be like, oh my gosh, look at what was going on back then. They even had, your doctor was recommending what kind of cigarettes to smoke. I don't have any pictures of pregnant women, but there were some ads with pregnant women smoking, which like today we'd be like, oh my gosh. But I do want to talk about this thing that happened that was both brilliant and unbelievable. Virginia Slims developed a campaign and they latched on to the feminist movement that was happening at the time. And so they tried to make it appear that if you were a woman who chose to smoke their cigarette, you were following the feminist movement. It was sort of like it was your right to be able to enjoy cigarettes very much like maybe your husband smoked cigarettes and your daddy smoked cigarettes, or your brother got to smoke cigarettes and enjoy them. But in the past, you weren't allowed to enjoy them, but now you can, because and the slogan that they came up with, and I think back about this now, how offensive it is, but you've come a long way, baby. So the you've come a long way is the feminist movement, which I think that part is pretty positive. But baby, I don't know about you all, but I don't even really like being called lady. I definitely don't want to be called baby by somebody. It sounds very patronizing. And it sounds very much like putting a woman into her place. But the Virginia Slims campaign was incredibly successful. And it wasn't an accident that they called them Slims either, because what they were also attaching to is women's desire to be thin. And you saw a return to an ideal body size in the 60s to being slim. Slim and not muscular, like kind of our cultural ideal is today, but creating a cigarette that was slim compared to, I guess, the chubby cigarettes that men smoked, as well as what they were latching onto is the fact that a lot of women smoke because they smoke instead of eat, or they smoke and it raises their metabolism a little bit. And I've done some research, it's been a while, with a student that I worked with, but the research suggests that beginning smoking doesn't help women lose weight. But when women have been smoking for a long period of time, when they quit, they on average gain about 4 or 5 pounds. And for a lot of women, that scares them. That's not much weight gain, but it scares some people, and they're afraid, oh, if I quit smoking, I'm just going to gain and gain and gain and gain. But I can tell you certainly from a health perspective, gaining 4 to 5 pounds is nothing relative to the dangers of smoking. But they were clever. They were clever in all the stuff they latched onto that would bring women into their brand. And cigarette advertising has been important for the tobacco industry because tobacco users are very loyal to their brand. So if you can get them using your brand, they are likely going to use that brand forevermore until the cigarettes kill them. Okay. So, yeah. Okay, I'm not going to go into that. I do want to talk about this thing called, you'll sometimes see in the cancer field, and this again is just getting some language down if you've heard some of this language. When they talk about 1-year survival rate or 5-year survival rate or 10-year survival rate, what they're getting at is what is the likelihood, and then they track this stuff over time, when you're given when you have a certain type of cancer and you have a certain type of staging, what is the likelihood that you're going to, what percentage of individuals live a year, live 5 years, live 10 years? It gives some prognostic information there. And I know this is really blurred. I'm not going to go into this. I just wanted us to kind of get that language down. Okay, when we talk about those things that mutate those oncogenes and those suppressor genes, there are quite a few known things that can do that. So let's first of all talk about viruses that can do that. And many of you women know that when you go and get a pelvic and a pap test, and they get in there and they shave off some cervical cells, and then they send those cells to a pathologist, if there's any abnormality in those cells, and that's called dysplasia, meaning the cells are malformed, dysplastic. If there is dysplasia, we're going to talk a little bit more about this later, there's all kinds of things that they can do to treat that. And the point of it is capturing any bad cells on the tip of the cervix before it grows into the uterine lining and can become uterine cancer. The only reason why women get cervical and uterine cancer is because of a virus, and that is human papilloma virus, HPV. And HPV is very common in women. It's common in men. It tends to be a sexually transmitted virus. And so women can acquire it internally from digits. They can acquire it from a penis. They can acquire it orally in sexual activity. And a lot of women have HPV. The good thing, well, there are a couple good things about that, is that a lot of women's immune system, if they get HPV, their bodies clear it. Okay, they clear it, the immune system gets rid of it, no big deal. Some of the HPV strains create genital warts. Some of the HPV strains do not create genital warts. But again, if women are doing that pelvic and pap and they're getting screened on a regular basis, should this create any type of mutated cells, the pap test can catch it quickly. And then there are different techniques that gynecologists can do to either freeze or burn those cells and monitor a woman more frequently if she's had some abnormal cells. And so rarely does it grow into uterine cancer that kills women nowadays. Okay. And part of the controversy about the vaccines, and keep in mind, guys are given the HPV vaccines also, because they can get sick from HPV. Like Michael Douglas had esophageal cancer, and it was attributed to oral sex. He acquired it through oral sex and had HPV in his mouth and his esophagus. So men have this too, and they transfer it too. Oh, I had a point there. Oh, but it's not killing people because of the screening is rather effective, and the treatments are rather effective. So that's where there's some of the controversy about the vaccines, like how necessary are they or not necessary, is some of that controversy there. Hepatitis B and certain liver cancers are caused by viruses. A lot of people who have reflux or GERD, they used to just treat that with antacids. Nowadays, they test for bacteria and they'll treat with antacids, but they'll also treat with antibiotics. Helicobacter pylori is a bacteria that a lot of individuals have in their throat and their esophagus and down in their stomach that tends to cause ulcers and tends to cause cancer. But again, that's treatable if it gets diagnosed correctly. So these things don't have to necessarily be life-threatening. The genetic mutations can be inherited. And again, I want to warn any of you in this class, if you've got a family history of breast cancer, ovarian cancer, particularly if it happened to people in a younger age, premenopausal, you might want to entertain the seriousness of that, because you could be a carrier of one of the BRCA genes that tend to cause cancers early, particularly breast and ovarian cancer in women. You can acquire the mutation over time. So an example here is a lot of sun exposure could spin out melanoma. So that would be sun radiation mutating skin cells in a way that would spin out melanoma. Carcinogens, there are a bunch of carcinogens in tobacco products, but these are any kind of things that can cause genetic mutations. So sometimes they're chemicals, like in tobacco products. Sometimes they're other things. Anything that's injuring those oncogenes and those suppressor genes can spin out cancer. So these are some of the common carcinogens. The cigarette smoking, lots and lots of known carcinogens, and it's really like if you get a pure form of nicotine, that's going to be carcinogen free, but pure forms of nicotine are pretty expensive. We're seeing a lot of, with the increase in vaping, we're seeing more risks of individuals with that. Passive smoking would be being exposed to other people's smoke. Cigars, chew, smokeless tobacco, those have carcinogens in them too. The saturated fat in red and processed meats can be carcinogenic. And again, back in the day, when they were preserving foods by smoking foods, they were actually unleashing carcinogens in the meat to preserve it, and that was driving the stomach cancer. Alcohol is a carcinogen. I know back when I was out doing a wine tour out in California in Napa, every single winery where you would walk into would have these signs, and they had to have them posted legally, and it would say alcohol can cause cancer. And it's like, when you're going wine tasting, that is not the message you want to hear. Like, you're running my fun here. But it's true. It is a carcinogen and it causes cancer in individuals. Radiation is a risk factor for cancer, and it could be environmental radiation, like if you are exposed to a nuclear plant meltdown, that could be very dangerous. Being exposed to sunshine radiation can be dangerous. But in a lot of situations, it's medical radiation. My nephew developed leukemia because he had been exposed to a lot of, probably because he had been exposed to a lot of x-rays for a bone disease. My mom's undergoing a radiation treatment right now that the data looks very successful for the type of cancer that she has, but now there's a risk factor that she could develop a different type of cancer down the road because of the radiation treatment. Robin Roberts, the sports announcer, that was her story. She had breast cancer. I love Robin Roberts. I actually sat next to her in a restaurant at one point and I left her alone, but I was just like, oh, there she is. She had breast cancer and they successfully treated her breast cancer. And she was very public about this on the morning news show. But then years later, she developed a weird blood cancer from the radiation effects and then had to undergo some pretty grueling treatments to survive the second round. So at times, it's medically driven. Again, thinking of saving somebody short term, but setting them up for longer term risks. Toxic chemical exposure. If you're around, in a region that has been exposed to that kind of thing. We have in our house, we have a crawl space and we're sitting on a rock and we have radon mitigation. And so they collect the air underneath the crawl space and then it goes up into the sky and miraculously goes wherever. But we have, and we see that a lot around here in the mountains. Radon is this carcinogenic gas that comes up out of the rock formations. And so many individuals will test for that. And when they buy homes, they'll test for that. But we've got our mitigation and I'm pretty sure we're good. Protective factors. A lot of this stuff is going to come with all the lifestyle stuff we've talked about already this semester. Ideally, we're limiting those saturated and trans fats. Ideally, we're eating a lot of the healthy antioxidants that you find in the pigmented fruits and vegetables. I don't know about you all, but I love spicy food, Thai food, Indian food, and those different types of spices, garlic, ginger, turmeric, that's the one that stains your Tupperware, different types of curry mixtures are really healthy for us. If you like those kinds of foods, do what you can to consume them regularly. The unsaturated fats, and remember we talked about fats that are liquid at room temperature tend to be the healthiest ones, that the ones that come from plants and oils. We've talked about the healthy fish fats and the fats found in flaxseed. So if you don't want to do fish, you want to do plants. Exercise on a regular basis. When we exercise on a regular basis, and this is actually Dr. David Neiman's research, he's in our exercise science department. When we exercise on a regular basis, our immune system does a much better job of keeping us from getting sick from pathogens. And our immune system does a much better job of protecting us against cancers. There's even research now that regular exercise is protecting individuals if they contract the coronavirus, have a less severe disease course. So again, humming along with a nice healthy immune system is a great thing to have. And these kinds of foods and the exercise, green tea is anti-inflammatory. And I know for individuals who have autoimmune diseases, they're recommended they drink a lot of green tea. I tried to up that this winter just because there's some really nice data to show if you contract coronavirus, green tea can be protective. Having a healthy body weight, limiting sun exposure, your generation, you're the sunscreen kids. My generation, I was not a sunscreen kid. I go to the dermatologist every 6 months and hope I don't get holes poked in me. I am in the generation, me and my friends, we are regulars to the dermatologist. My parents used to oil me up and stick me in the sand on the beach. No sunscreen, just oil me up. They wanted a little brown baby instead of a little white baby, I think. And so I'm paying for it a bit. The whole grain foods, the fruits, the legumes, the vegetables, particularly the stuff that's most pigmented. There's a lot that we can do with our nutrition to protect us against developing cancer. But then also, I've known a lot of individuals, once they've been diagnosed with cancer, they go hardcore changing their diet, getting their exercise, doing their stress management, doing their yoga. Cheryl Crow's written a book about that. She's got this really, if you want to look at her book, she's got this really hot chef that she's written a cookbook with. But after her breast cancer, she really changed her diet, and then she's written a cookbook about it. So a lot of individuals get very motivated once they're diagnosed with cancer. So again, our immune system, and particularly the natural killer cells, are pretty effective at finding cancerous cells and getting them out of the body. We know that chronic stress downregulates our immune system. If we're chronically stressed and we're using energy for other things, our immune system doesn't have enough fuel and enough energy to do its job well. And we know that chronic stress makes us vulnerable to developing cancer. And we know that once an individual has cancer, their level of stress is going to predict their outcome. Okay. So again, when I'm talking about people getting diagnosed and then going hardcore on the yoga or the meditation or the Tai Chi or whatever it is that they're doing, that is a smart thing to be doing. Anything that you can do to boost your immune system is good. Any questions so far about anything? Okay, so I showed you some of that data across time, last 100 years or so, just to give you a feel for the most part, everything has stayed stable, with that exception of the lung and bronchial cancer, and that is attributed to tobacco products. So most cancer is stable, other than the lung cancer. Overall, and I don't mean to demean the scientists and the oncologists and the hematologists, but overall, the treatment has not changed a whole lot. Where we've actually had most success is a public health approach where we do secondary prevention. And secondary prevention is when we catch signs and symptoms of disease early, and we treat it early before it goes into full-blown disease or before it kills individuals. And when it comes to cancer, finding cancer early, that's what it's been all about. And you all, many of you are already doing some of this stuff. So let's talk about the screening. Our 5-year survival rate on average is about 85%. But so much of that is due to earlier screening and earlier diagnosing. Okay, so our screening guidelines, trying to move my gallery around a teeny bit here so I can see what I'm doing. When it comes to breast cancer, the majority of breast cancers are actually detected by the woman herself doing her self-breast exam. Okay. And I will put that YouTube up for you all on how to do that. Hopefully, most of you are doing this yourself. Tell me the time of the menstrual cycle that we are supposed to do our own self-breast exam. Somebody shout it out. You might not know. Okay, if you don't know, then it is post-menstrual period. Okay, because a lot of women premenstrually, particularly if you have any fibrocystic kind of stuff going on, you get these little water nodules, these little cysts going on in your breast, and breasts can feel kind of heavy and lumpy premenstrually for some women. Postmenstrually, they are going to be deflated, for lack of a better word. And so what you're feeling in there after your menstrual period is likely your true breast tissue. And so one way of thinking about it is when you put pads and tampons away, if you get a monthly period, then that is the time to check your breasts. And again, the majority of breast cancers are detected that way. The friends that had friends who have found it themselves. I have had friends who've had breast cancer they found it in a mammogram. Ideally, we're getting a clinical exam. And if you go to your gynecologist yearly, you get your pelvic and your pap. Some of you are getting contraception that way. Usually your healthcare provider does a breast exam once a year, but it's recommended ages 20 to 40. We're getting that every 3 years, and then yearly after the age of 40. So now let's talk about mammograms. There's been some controversy about the age at which mammograms were supposed to start, because originally doctors were recommending mammograms starting at age 40 in women. And then when you looked at the public health data, what you found is that so many women, when they start at age 40, and I was the generation where they sent me starting at age 40, so I've had my share of mammograms. When you start at the age of 40, you get a lot of false positives. And I have had friends who've had those false positives where they go and they get their mammogram and they see something and it's scary. And then they have to go and have all these tests done. They have to have biopsies done. They're terrified. They've got breast cancer, and they don't. When you start doing the testing after the age of 50, then it's much more successful at catching real cancers. And so when we talk about what's going on down here, 97% in age 40 to 49 will have an abnormality and it's not cancer, but that lowers after the age of 50. Okay, but mammograms are very sensitive. If there's anything going wrong in there in the cells, whether it's cancerous or not, the mammograms are really good at picking that up. Okay. Usually if there's something abnormal detected, they follow up with an ultrasound, they follow up with biopsies. And overall, this has been quite successful at reducing the cancer deaths from breast cancer over time. Okay. For women who, after they do a Pap test, and this is where this healthcare provider is going in, where they spread vagina, and then they go in with this stick-like thing that has fuzzy edge on the end, and they scrape off some cervical cells, and then they send those cells to a pathologist who looks at them under a detailed microscope and looks to see if there are any abnormal cells. If there is cervical dysplasia, just kind of like we mentioned earlier, there's a lot of different things that they can do to treat those cells to keep them from growing into cancer. They will oftentimes also, if a person has cervical dysplasia, if you've got any of those abnormal cells, then they'll test for HPV. But keep in mind, the Pap is not testing for HPV, the cause of the cervical dysplasia. The Pap is just testing for abnormal cells. But then a lot of people want to know, if they've got the dysplasia, are they carrying HPV? And again, like I've said, in both men and women, HPV is quite common. It is sexually transmitted by contact, but okay. What I don't expect for y'all to memorize all of this. I want you to know that American Cancer Association sets the guidelines for healthcare providers in what kinds of screenings that they do and how often they do their screenings. And they changed these guidelines for the Pap and pelvic recently. They used to want to recommend that you started at age 18. Now they're saying individuals should start this 3 years after intercourse begins. And I don't want us just to be thinking about intercourse as heterosexual penis to vagina intercourse. This could be anal intercourse. This could be digital types of intercourse for homosexual women also. So this applies to anybody regardless of their sexual orientation. It is possible to be transmitting. So know about those guidelines. Colorectal cancer in the US, they're now recommending that we get screened after the age of 50. If you have colon cancer running in your family, they recommend you go get that at an earlier age. Right now, this is a kind of a surgical procedure. Most people want to be out for it, or they want to be sedated because they go in through your rectum, they take a camera all the way up through your intestines, and if there's anything abnormal in there, they try to take it out. There are also nowadays some non-invasive tests where you can send your feces to a lab and they look for cancerous cells shed in the feces. I think they're going to get much better at the non-invasive tests. So maybe by the time you all are 50, you won't have to go in for colonoscopies. Okay, so breast cancer second in women after lung cancer. 1 in 8, 1 in 10. Again, it depends on if you're looking at postmenopausal, premenopausal. This example here of this picture, this is a horribly advanced form of breast cancer. Okay, horribly advanced in this poor individual. Survival for women is 100% if we detect it in the original tumor. And again, that's a good reason for doing your self-breast exam. That's a good reason for when you're at that age, your doctor's recommending going and getting the mammogram. We are very successful if we can catch that when it first starts. Our survival rate is up since the 1990s. And just like we talked about the other day, that's because we're doing a lot less hormone replacement treatment, because that was driving up rates of breast cancer. And once doctors stopped prescribing that on a regular basis for women at menopause. When we look at known risk factors for breast cancer, being over the age of 50 and female. And so menopause not only increases cardiovascular disease risk, it increases breast cancer risk. Women who had started their menstrual periods earlier on average than other girls, and then women who've had a late menopause, the longer the length of time that we have been exposed to our natural hormones, the more likely our risk of breast cancer. The lesser the amount of time we've been exposed to our natural hormones, the lower the risk. Okay. If we have been prescribed and took a hormone replacement therapy, if we have any of these family histories for any of these BRCA genes, and there's some interesting controversy about getting tested for these genes. And the controversies are on a couple different layers. One has to do with if you get tested and you're positive for one of these genes, do you now have a pre-existing condition? Keep in mind right now, insurance companies cannot deny us for pre-existing, but pre-Obamacare, they could deny people for pre-existing conditions. And so there was kind of that controversy. Other things that are kind of delicate for certain families are, let's say we've had, and this is not the case, I don't have these BRCA genes, I don't have this in my family history, but let's say grandmother died early, mother died early, and I want to go get tested because I want to know if I've got one of these BRCA genes, because it could mean I screen more thoroughly. It could mean I go full-blown Angelina Jolie, and I decide to have a mastectomy, get my breast removed. I decide to have a hysterectomy, get my uterus and my ovaries removed. And she did, because her mother died early and she was carrying the genes. So she went hardcore prevention and had all of that done to try to prevent her from developing breast and ovarian cancer. But let's say I go and I get tested and I'm positive, but my sister doesn't want to know my results. My sister doesn't want her daughters. My sister does have 4 daughters. She doesn't want her daughters to know my results. And so it gets delicate. Does that make some sense? That sometimes we want to know, sometimes there's repercussions. Sometimes people would rather not know. Sometimes people would rather know, like, okay, what am I in for potentially? And am I going to do something about it? I have a friend who's positive for one of these genes, and she's just doing very careful medical surveillance. Like, that is her plan right now. Very, very diligent and regular medical surveillance for that. Being childless, so never having a baby or giving birth after the age of 30. And that's not a reason to go make babies early, but it is a legitimate risk factor. Being on an unhealthy diet, particularly a high-fat diet. And keep in mind, the high-fat diets tend to be associated with the lack of the rainbow diet stuff, you know, so when people are doing the brown stuff, they're not doing the rainbow diet stuff, which is protective. This is part of the reasons why this stuff is psychologically scary. Even all the stuff we know, we only predict about 15% of the variance. So it's just one of those things, like it can get people kind of what seems like at random. And so that's kind of scary. You know, we're all vulnerable in some kind of way. And keep in mind, men do get breast cancer. Okay. It's not just a female thing. Men do get it. I knew a man who had breast cancer. And thank goodness he detected it early. So they do, but we're just more at risk, particularly because there's a pattern you see in here. Particularly if you have the genes, and these genetic risks are oftentimes genetic risks for estrogen-fed cancers. So part of the reason why somebody like Angelina Jolie decided to have a mastectomy and get her breast removed, so then she doesn't have any breast tissue that could get cancer. But then she went further and had her uterus removed because she was at higher risk for estrogen-fed uterine cancer. But then she had her ovaries removed, which, keep in mind, any woman who decides to do this, it sends them into a very abrupt menopause. And that is not how we are wired to do menopause. We're meant for it to kind of creep in. And then we sit with it for a while, and then it kind of creeps away over time. It is not meant to be abrupt. Okay. But when you get your ovaries removed, it is abrupt. But again, ovaries are producing estrogen. So she and other women have decided, get rid of all the organs and let's get rid of all the estrogen that could be feeding these cancers. Okay. So part of the reason why women have less breast cancer is they don't have as much estrogen. Questions here? The protective factors, breastfeeding is really good. Breastfeeding, and the more pregnancies you have, again, this is not a reason to go to have a slew of babies. But when we are pregnant and when we are breastfeeding, we don't have the normal menstrual cycles. We're not exposed to our own natural hormones. And so that's part of that. Women who exercise on a regular basis tend to have more normal levels of sex hormones. And so that can be healthy, as well as it's boosting the immune system. And women in a healthy body weight. I can't remember if we talked about this when we talked about obesity, but some fat cells can actually produce toxins that can be dangerous. So some of the healthy body weight is that. Okay. So incidence would be number of new cases. So we're not talking about death here. This would be number of new cases. And we have seen actually relatively stable rates of breast cancer over time in women. Every now and then we'll get a scare. I know there was a scare a while back of like, if you get your clothes dry cleaned, that's a risk factor for breast cancer. There have been some scares about uses of certain types of deodorants or antiperspirants, that type of thing. So treatment of cancer, we have a lot of individuals out there who are cancer survivors right now. Surgery offers the most hope, particularly if there's a solid tumor and it's a small tumor and it's caught early. That is what is the most helpful. And there are only a few places in the body, particularly deep in the brain, that surgeons can't get to. Okay. And so getting in there and removing a tumor, removing the tissue around the tumor. And then what they oftentimes will do is, after removal of a tumor, prescribe radiation and do radiation that gets in there. If y'all had trigonometry and you had no idea why you were learning trigonometry, trigonometry is all about waves. And different types of radiation treatments, they're going to do different types of waves to get certain depth in the body, certain safety in the body. And so our radiation therapists and our radiation oncologists, they're using their trigonometry. So if you've known anybody who's had radiation therapy, a lot of times individuals will report fatigue after radiation therapy, but will also report wherever in the body that they've experienced it, what feels like a dramatic sunburn. Okay. I had a client at one point where she had developed rectal cancer and had to go in for her radiation treatment. And she said they would put her in this harness, and she would be in this harness, and then they would insert this radiation electrode up into her rectum, and then it would radiate internally the cells to kill the cancer that she had developed in her lower GI tract. But what was happening to her, and the reason why she was referred to me, is she was not participating in her pelvic floor physical therapy. And she had been in this horrible relationship. She was not with a partner at that point in time, and wasn't sure she ever wanted a man in her life or in her bed ever again. But what was happening with the radiation in her rectum, it was burning in her pelvic cavity, and her vagina was adhering to itself. Like, she was no longer going to be capable of any type of penetration because the burn was just like basically kind of melting the cells together. And so the reason why she was referred to me is to see if we could help her develop some self-respect for her body, and if she wanted to preserve her sexuality for herself, and maybe not, with a partner in the future, she needed to take care of her body, and she wasn't doing that. And she was a lovely lady, and she was willing to do that. And between me and her physical therapist who was doing her pelvic floor work, we got her back to a normal sexual functioning. Chemotherapy, anytime we take a medication for anything, technically that's chemotherapy. You know, if you take an aspirin for a headache, that's chemotherapy. But it's just become so associated with cancer treatment therapies, okay? And that's why we call it chemo. And there are a variety of different types of chemo, and they're all designed to take a look at that very particular type of cancer. And the ultimate goal is to get inside the body, find the cancerous cells, kill them, but not kill healthy cells. And so a lot of times when people are doing chemotherapy, the side effects make a lot of sense when you understand how these medications work. So fatigue. If you've got cancerous cells that are dying and your immune system's trying to clear those from the body, and you've got healthy cells that are dying, your immune system's trying to clear those from the body, your immune system's taking up a lot of energy, and that person's going to experience fatigue. Second way of thinking about that, some chemotherapies try to capture and kill cells that are replicating very fast. And I want us to think about the parts of our bodies where we have cells that are replicating very fast as opposed to quite slow. Hair. Hair replicates very fast. So certain chemos, people have hair loss, okay? You hear about the hair loss on their head. You don't hear about the hair loss on other body parts, but they're losing it in other body parts too. What other side effects do you normally hear about for some individuals on certain types of chemo? Somebody give me a side effect while I take a drink.
Well, this isn't with chemo, but my dad actually just went through radiation, and because he had cancer in his jaw and part in his tongue, so he had to get like part of his tongue removed and used, but he had to go through radiation afterwards, and he actually lost his taste because he had the radiation. So you like have loss of different, like, you know, functions like feeling in different parts for radiation, I know.
Yeah. Yeah. Thanks for sharing that. Yeah. And that makes perfect sense. If it's in his jaw and his tongue, whatever sensory effects you had from those organs, you might be losing that. Yeah. What else? For men getting prostate cancer radiation, oftentimes there's impotence and not enuresis, that's bedwetting. It'll come to me. Incontinence, that's the word I'm looking for. Yeah. So, I mean, it would make sense if you're getting that area of your body that you might have side effects in genitals and with urination and that type of thing. The most common kind of stuff that we hear about, though, is the nausea, the vomiting, and then you don't hear about it, but it's happening, the diarrhea. And a lot of that is that the cells in our GI tract replicate very, very quickly. Okay, because you got a pretty harsh environment going on inside there. So it makes sense that those mucosal membranes would be replicating very quickly. And then even think about like in the very beginning of your GI tract, when you bite your lip, or when my son was little, he fell when he was a toddler, he fell and he bit through his tongue. He had a hole in his tongue and I was like freaking out, but it was healed the next day. It was like healed. How quickly those cells heal, like again, you bite your cheek and then by the next day it's good. GI tract cells replicate very quickly. So it makes a lot of sense that when you get in there and try to kill those cancer cells, but you're killing the healthy cells, for a lot of individuals, the GI effect is like, I'm not digesting anything. Leave me alone, kind of, yeah. Some of the alternative treatments, there are alternative treatments that are quack, and there are alternative treatments that we know to be quite effective. And the way I kind of simply think about it is any alternative therapy that improves lifestyle behavior, lowers stress, bolsters the immune system, that is going to be beneficial. And so we've already talked about a lot of that, the exercise, the stress management, the yoga, the changing way one eats if one was not eating very healthfully. those things are really good. So from a biopsychosocial, and I should have added on here spiritual, because certainly a cancer diagnosis, whether a person is religious or spiritual or not, will encourage individuals to kind of consider their spiritual faith beliefs, or if nothing else, a lot of times individuals simply do a why me? Why me? That type of thing. And again, some of the randomness of cancers, it makes sense that there's fear. It makes sense that there's kind of the why me. So when psychologists get involved in cancer, and I can tell you there are health psychologists, particularly at these big medical centers all across the United States and the world, that is what they do. They just are totally specialized in cancer. One of my former students, Dr. Christy Graves, has family experience with breast cancer, and she went and got her PhD in clinical psych and then postdoced, and and then she's studied additionally on top of that in genetics and whatnot. She is a cancer expert. She's a clinical health psychologist who's an absolute expert in this area. So some of the issues dealing with pain from certain cancers, the fear and the anxiety of getting a test and waiting, and then what's going to be my treatment and waiting. I know with both of my parents have had cancer and are surviving cancer, but I know particularly for my mother, it's been a long haul in trying to understand a very rare form of cancer. I gladly get called in every now and then. I'll read scientific articles and I start Googling what terms mean. But she's on a very new treatment. Again, scientific data looked quite successful. She was very, very concerned about what am I going to go through if I decide to go through this new treatment. But it's actually been not nearly as bad as she thought it was. And again, scientific data is very hopeful. So it makes sense that there's a lot of this kind of stuff going on. Disability, if people are having chemo or radiation and they have to go down for a couple of days and they're not able to function. Disfigurement, which is something that we definitely are helping individuals deal with. You're going to see, if you haven't watched the Spiegel Metastatic Breast Cancer Support Group, that's a documentary I want you to watch. If you haven't seen it now, you want to watch that up on As You Learn after this lecture. And you will see, at least there's one woman, it's noticeable, she only has one breast and decided not to do a bra or prosthetic or get a replacement. But issues of, if you've got a sexual partner, like my body's not the way it used to be, and do I just have disdain for that, or I'm like, thank goodness they got that thing off my body. Scars, I've known women that say they've gone and gotten a tattoo and then might wear a particular bra that kind of hides the fact that they've lost a breast. And the tattoo's kind of celebratory, as opposed to somebody who really just, really worries about how they look. Issues with a partner, is my partner going to still love me and find me to be attractive? Is my partner going to be afraid that I'm going to be afraid? All that kind of stuff going on for individuals. Sigmund Freud, the pictures you see of him, he's always smoking his guitar, again, not guitar, his cigar. And I don't think he played the guitar either. But he ended up with horrible oral cancer and had to have these surgeries and was disfigured and was in all this pain, and he had to have this device that he used. So that would be an example of disfigurement caused from that. The financial stress, particularly if somebody's not well insured and it's not covering their treatments and the relationship issues. I've worked with a good bit of couples and families when somebody's dealing with cancer. There's a common norm, and you're going to see this in the documentary, where Spiegel particularly is trying to help a daughter and dad through mom's cancer. A lot of families are afraid, they don't want to talk about this stuff because they're afraid if they talk about it, they're going to upset the person who has cancer. And my philosophy about that is that it's not the talking about it that's upsetting, even though the emotions might come out in the talking about it. It's the having it and the going through it and the going through the treatment that is the upsetting and scary part. But it's oftentimes really hard for people to talk about this stuff. And so psychologists sometimes get brought in to help deal with that. I worked with this one family at one point in time where it was the dad in the family that had the cancer, and he'd been working with me. It was really delightful to work with me, but his whole family was in like this denial. Like he's terminal and they're in this denial. And so we brought them in. He wanted my help, and we brought them in to talk about his cancer and his treatment and the fact that he was dying. And that was therapeutic. Like people needed to do that. Nobody knew how to get it started. And then the second thing he wanted to do, he was a character. He wanted to plan his funeral before his funeral because he didn't think his family was going to do it right. He didn't think they were going to do it the way he wanted it done. And darn it, he wanted it done the way he wanted it done. And then not only that, he wanted his funeral plan. He wanted to have a celebration of life before that. Like he wanted to have a funeral where his family and friends were there, and then he wanted them to have a funeral after he passed also. So we did a lot with that family. They were a sweet group. Simply put, the disease is punishing. The treatments can be punishing. Another time that psychologists get called in is when individuals are making a decision to cease treatment, or they've had cancer, they've been treated, it goes into remission, and then it comes back. And doctors are recommending treatment, family members are recommending treatment, but the patient doesn't want the treatment. And so psychologists sometimes get called in to do competency evals to determine, hey, is this person making a rational decision? And do they have every right to make a decision to refuse treatment? But a lot of times there's legal issues there and there's family issues there. And so psychologists get pulled in for that. My former student, Dr. Christy Graves, her main area of research is decision support. And it has to do, if you've known anybody who's been through these kinds of cancer diagnoses and treatments, you've felt this before, where you need all the information, but you need it boiled down in a way that a normal human being who is not an oncologist, hematologist can understand the information. And then the opportunity to make your own decisions. And so there's a lot going on in that. So as an example, nowadays, particularly for younger women, when they get diagnosed with breast cancer, it used to be that the doctors got in there and they got that tumor and they wanted the radiation, and then they would give these women the chemo. So it, just in case it ever sneaks back and it wants to come back. But what we found over time, particularly for younger women, if you give them chemo, you are creating mild, if not severe, brain damage. And I know I worked with a younger woman who, and I think about this myself, like my whole career is my ability to think. And this woman that I know was a younger woman in a very successful career and had breast cancer, had radiation, had chemo, and had so much memory damage that she could no longer function in her career. Okay? So nowadays, as an example, women are given a lot more choices in that. And I think that's a really wonderful thing so let's say the doctor says, okay, well, I'm going to get in there, take that tumor out. I'm going to take bigger margins. So you don't have to have radiation, or you could do both and have the radiation, but I'm not, you can do the chemo if you want to take the risk, or we can decide not to do the chemo and let's just monitor you closely to make sure if your cancer comes back, we catch that early again. So just the same kind of thing for men with prostate cancer, older men who don't have much of a sex life left, who are likely going to die of something else. Oftentimes they'll do a watch and wait. Like we're not going to go in and remove your prostate and radiate and give you incontinence where you have to wear a diaper if likely something else, if we just watch and wait. So I like that. I mean, I like the idea that there are more options given, but again, it has to be given to the patients in a way that they can comprehend it. They can think about their personal lifestyle and what risk they're willing to take versus what risk they don't want to take. There's a lot going on in that. Helping people cope with the stressful effects of the side effects of disease treatment, coping with the disease. So there's lots of stuff that psychologists get involved in. From another psychological standpoint, we know that individuals who are optimists are more likely to be successful at coping with cancer. And a lot of that has to do with like, oh, this is bad, but I want to live a full life. And so what can I do? Can I change my diet? Can I start exercising? Can I start that yoga practice on a regular basis? Can I be more open with my family and my friends about my emotions, that kind of thing? So the optimists are more likely to take something bad and try to spin it into the glass is half full instead of the glass is half empty. People with an internal locus of control who like doing all the things that they can do to problem solve are more successful than people with an external locus of control, sort of like, nothing I can do about it. With the one exception, the one place psychologically external locus of control seems to really benefit health is a belief in God or Allah or a higher power. That idea of she is working up there in mysterious ways, carrying me at times. And I'm going to do all that I can to respect my body and try to get healthy and heal from this. But there's a piece of it that is outside of my hands and outside of my control. Okay. That's actually a beneficial thing. But I will add one more caveat though, especially if people believe in a loving God. If people have grown up with a faith history where it's a fire and brimstone, and if you sin, you're going to hell, that's not nearly psychologically as beneficial as God is love, and God cries when I'm hurting. That type of, does that make sense? Very different kind of different messaging and different religious beliefs going on there. Okay. We know that Penny Baker, he's a social psychologist, but he was the one, he called it the writing cure, but he's the one that we talked about earlier in the semester when we talked about stress. Particularly if you take a traumatic event or a stressful event and you write about the event over and over and over again, and remember it goes from all this emotion stuff early in the writing to acceptance and problem solving, whether it be emotion focused problem solving or action focused problem solving. There's a lot of literature in the cancer field of how helpful that is for individuals to write repeatedly about what they're going through, to talk repeatedly. This is why it's really good to be able to open up to friends, to have family members come and inquire how you're doing and being able to open up to them about their cancer treatments. I know, I'll just share this one little story. It's a sweet story about my mom. She was very worried early on in her cancer treatments certainly she was worried about getting sick and worried about dying and, all that kind of stuff, but she was really worried about losing her hair. And she could talk to me about that because I understood that. I would not like that either. And I could just get that. But she was afraid of telling other people that worry, because a lot of times what you get with that kind of stuff is like, that should be the last thing you're worrying about. You're alive. Don't be worrying about your hair. But she called me up one day after one of her treatments, or after she'd been on some treatments for a while. And she said, "It's finally happening, Denise, I'm losing my hair." And I was like, oh no, oh, we're going there, that type of thing. But then it occurred to me, like it took me the next day. And then I realized because of her cancer, she's struggled for a long time with malnourishment. And then it occurred to me, and I remember when I was in inpatient eating disorders, how many of the women's who had eating disorders, their hair was breaking. It was brittle and breaking because of malnourishment. So I call my mom back up that day and I'm like, "Ma, is it falling out at the roots or is it breaking in your hairbrush?" And she said, "It's breaking in my hairbrush." It's like, okay, that's malnourishment. You need to go back to your doctor and get detailed checked on the malnourishment. And that's what was happening to her. But again, that's something that there was something they could do about. And now she's on some supplements and some shots to kind of help with that type of thing. But it's one of those things where, and this happens a lot of times, I think, for people with cancer, there's stuff that it's hard for them to admit to, or it's hard for them to talk about, but it's real. It's like real for them, whatever it might be, whether it's a vanity kind of thing or a fear kind of thing. I've known some individuals who are just really afraid of living with very poor quality of life. And it's like, yeah, makes sense. Okay, so I want you to watch the Spiegel documentary. And this is David Spiegel. He is a psychiatrist. He's a faculty member out at Stanford University. And his original study that he did, and he was kind of he did it for reasons other than I want to see if this helps women with breast cancer. But he took this group of women who had metastatic breast cancer, so it had spread to other parts of their body. He randomly assigned them. All of them got treatment as usual. So their medical treatment, it was whatever their doctors were recommending. But half of the women who got randomly assigned to the experimental group, they met weekly in a support group. So they were meeting with women who are all in the same kind of situation that they were in. And one of the things that Spiegel and the other therapists that were leading these groups, one of my colleagues in graduate school who was ahead of me, she went out there and she worked and ran these groups and was a researcher out there with David Spiegel at Stanford, encouraging the women to face their cancer, encouraging the women to think about their treatment options, support one another in their decisions. I'll give you a quick trigger warning. There's a couple of sad places in the documentary where they lose a woman in the group. So facing death, facing loss of a person who was in their group who they knew, making them face their own death, and what does that mean? And then he and the other therapists that run these groups were big sticklers for sharing emotions. Like, get in touch with those emotions and express them, get them out, don't hold them in. And there's actually some wonderful scientific literature to show when we hold in trauma memories, when we hold in difficult emotions that we feel like we can't express, that is harmful for us. It takes energy to do that, and it actually taps brain power to do that. So you'll see him encouraging them to express emotions. There's one part in the group where they're meditating and he hears sniffles, and he kind of tunes in, okay, like who's crying right now? And I want to make sure that, they're given an opportunity to talk about that. What he found, the original data from this research was spectacular. But since then, in replication studies, it has not been nearly as spectacular. But in the original 10-year follow-up, the women who'd been randomly assigned to the support group lived on average 36.6 months longer. Those in the treatment as usual, 18.9 months. So it essentially doubled their remaining lifespan. I want you to pay attention to, when you watch the documentary, Ramona. Ramona is my favorite character. I've seen these documentaries like 1,000 times. But Ramona is a great example of the type of person that benefits the most from going to a group like this. But Ramona is also the type of person who is not likely in the real world to go to a group like this. Because Ramona was raised that showing your emotions is a sign of weakness. And that also showing your emotions is a sign of selfishness, that as women, we should be paying attention to how everybody else feels and not necessarily thinking a whole lot about how we feel. Okay. But you see Ramona over time go from being this stoic character to being this warm and fuzzy, being able to share her emotions, being able to, she even says one day, yeah, I've absorbed some energy already, which is sort of, absorbing energy from other people. But again, the type of person who tends not to go to these groups is the type of person that benefits the most. Which is why in the follow-up research after this, a lot of the studies, the data kind of bounced around. We do know that these groups have continuously, if they haven't extended life, continuously helped women manage pain. And they have continuously helped them improve their quality of life. So not the dramatic extension of life, but still some good stuff in there. Here's what I want you to pay attention to, what's happening in the groups. They're in similar situations. They are sharing information, supporting decisions, that free expression of emotion, facing their treatment, facing death, coping with change, coping with disability, coping with disfigurement. You will not hear it in the documentary, but my colleague, Dr. Kay Sauer Hermanson, who went out there and worked in this program, she said there is a lot more discussion going on in groups about body image and disfigurement and sexuality than you're going to hear watching the documentary. Okay. And that makes a lot of sense to me, that a lot of these women are, they're grieving their old bodies. They're grieving if this has caused harm in a sexual relationship, they're grieving that. They may not want sexual activity anymore. And that's sad, for somebody to have to let that go. And then there's just a lot of, this is the warm fuzzy stuff that we have in clinical psych, but a lot of just unconditional positive regard. You're going to see the group seems to not like one of the group members, and then she kind of complains about it. But the therapist handles it really well. Like, we're not going to all gang up against her. It was very much of like, okay, well, what are you experiencing? What are you experiencing? He does just a really good job of sort of creating this atmosphere of like, I care for all of you and you're all valuable and your contributions are all worthwhile. So pay attention to that. Here's some. So it's Bill Moyers, the journalist, and you'll want to fast forward when you start. Well, I think if I don't have it queued at the right point and you're seeing stuff with John Kabat-Zinn and pain management, fast forward until 43 minutes and then it'll start the David Spiegel part of the documentary. Thoughts, questions, comments, anybody? All righty. Plan for next class, and I'm going to put some information up on As You Learn about this. But what I'm going to try to do is to get all of next week's lecture into one lecture. So I want you to watch some clips ahead of time. And the reason for that is next Thursday and Friday, we clinical faculty are interviewing applicants for our PsyD program. And so instead of me rushing and not having time to eat and trying to hold class and wedge that in between all these interviews, it would be easier for me, and then hopefully for you, if we just get through the material on Tuesday and don't have to hold class on Thursday. But I'll put some instructions up about that. Okay. Good seeing everybody. Y'all take care.